Hello, ladies and gentlemen. Welcome to Cardiology Lectures. I am Dr. Nik Nikam. I have been a cardiologist for 30 plus years at the Texas Medical Center, and today we are going to learn something about antiarrhythmic drugs. So let us begin. Before we proceed with the understanding of antiarrhythmic drugs, we need to understand the action potential that triggers the myocardial activity, and that forms the foundation for various antiarrhythmic drugs that we use in everyday practice. The resting myocardial cell has a resting membrane potential of minus 80 to 90 millivolts. When a signal reaches through the Purkinje system through the myocardial cell or the myocyte, an action potential is triggered, which goes from phase 4, the resting phase, to a phase 0, where there is sudden increase in voltage inside the cell, making the myocyte to contract. And there is, following phase 0, there is early repolarization, which accounts for phase 2, that is followed by the maintenance or a plateau, which represents phase 3 of the action potential of the myocyte. That is followed by repolarization of the myocyte, and it reaches phase 4, and with the next triggered impulse the action potential begins again. So this is the mechanism by which each myocardial cell is activated by the electrical impulse coming from the sinus node, the AV node, the bundle branches, and the Purkinje fibers. And the heart muscle acts on a all or none phenomenon. That is, if the electrical impulse is coming through the heart into the ventricles, the entire ventricle acts like single unit. That sounds pretty interesting, but how does this correlate to the electrical activity of the heart that we see on the electrocardiogram? If we were to superimpose the electrocardiogram on the action potential timeline, this is how it is going to look. This is the action potential of the ventricular myocardium we are looking at basically. With the sudden influx of sodium inside the myocyte, there is a positive deflection which is reflected by the QRS complex, and the plateau is reflected by the influx of calcium, which maintains the ST and part of the T segment. The ventricular repolarization is brought about in the phase 3 of the action potential, which is mediated by the sodium potassium pump through the ATP. Let's look a little deeper into the electrolyte changes that take place inside and outside the myocardial cells during an action potential. When a stimulus comes through the myocardial cell through a Purkinje fiber, the voltage inside the myocardial cell goes from minus 90 millivolts to almost 0 or 20 to 30 positive millivolts. And this is brought about by a sudden influx of sodium into the cell. And this early repolarization is represented by the movement of potassium from inside the cell into the interstitial space, and that is phase 1. Phase 2, which I talked about, the plateau phase, is brought about by the movement of calcium into the myocardial cell along with some movement of potassium outside the myocardial cell. The phase 3, which is the repolarization phase, is brought about by movement of potassium through the sodium potassium ATPase pump. Then finally, we have phase 4, which is brought about by calcium, sodium and potassium exchanges across the myocardial cells. You may be wondering, what in the world the electrolytes like sodium, potassium, calcium has to do with antiarrhythmic drugs? Well, since most of the arrhythmias occur because of excitation or re-entry and changes in the action potentials and the duration between action potentials, the antiarrhythmic drugs work on these various channels to alter the action potential and thus minimize the arrhythmia. Let's look a little deeper. Before I go into the actual antiarrhythmic drugs and how they act, I want to spend a couple of more minutes and talk about the pacemaker cells, namely the sinus node, the AV node, and even the bundle branches and the myocardium itself. As you know, the sinus node and the AV node, they have their own intrinsic rates. For example, the sinus node has an intrinsic rate of 60 to 100 beats per minute. How does the sinus node function without an external impulse? Actually, the resting membrane potential, which is flat in myocardial cells, is different in sinus node and in the AV node. Once the repolarization reaches the resting membrane potential, there is slow leak of electrolytes into the myocardium, which triggers the sinus and the AV node to bring about the next action potential. So they are able to spontaneously maintain a rhythmic action potential at regular intervals. As you can see, the baseline, the phase 4 of a myocyte is quite flat compared to phase 4 of sinus node or the AV node, which gradually increases in voltage, and when it reaches a certain threshold, it sets off another action potential. This is an important concept to remember. Class 1 drugs act on phase 0 of the action potential, which is involving the sodium channel. And the drugs in this category are Quinidine, Procainamide, Lidocaine and Flecainide. And within class 1, we have 3 different categories, namely class 1A, class 1B and class 1C, which we will look into in the future slides. The class 2 drugs are beta blockers, which act on phase 4 of the action potential, which is the resting membrane potential. Class 3 antiarrhythmics act on the repolarization phase or phase 3 of the action potential. And finally, class 4 or calcium channel blockers, which act on phase 2 of the action potential. I mentioned there are 3 different categories of drugs in class 1. So let's look a little deeper into these 3 different categories and the drugs which belong to each one of these categories. Class 1A drugs act on the sodium channel, that is phase 0. They also act on phase 3, which is the repolarization phase, as a result of which they prolong the QRS and the QT intervals. It's a very important concept to remember. The drugs in this category are Quinidine, Procainamide and Diaoprazole. The class 2B antiarrhythmics decrease the repolarization phase duration. They shorten the QT interval. You can see the difference. Class 1A, prolongs the QT interval, whereas class 1B shortens the QT interval. It also acts on phase 0 of the action potential, which is the sodium channel. Lidocaine, Miquelin, and Phenytoin belong to this class 1B antiarrhythmics. Now let's look at the class 1C drugs, which are acting on the sodium channel, but they do not alter the repolarization phase. The drugs in this category are Flecainide and Procainamide. The goal of using antiarrhythmic drugs. The ultimate goal of an antiarrhythmic drug therapy should be to restore normal sinus rhythm and conduction, prevent more serious or possibly lethal arrhythmias from occurring, such as ventricular tachycardia, fibrillation, or torsade. The antiarrhythmic drugs are used to decrease conduction velocity, change the duration of the effective refractory period, suppress automaticity, and block the normal and accessory pathways as needed to terminate a tachyarrhythmia. The drugs in class 1A category are Quinidine, Procainamide, and a few words about Quinidine and Procainamide. In the 80s, when I started practice, we were using Quinidine in patients with atrial fibrillation and for conversion of atrial flutter to sinus rhythm. Rarely do we use these drugs for supraventricular arrhythmias in today's practice. However, oral Quinidine or Procainamide may be used along with class 3 drugs such as Amiodarone in patients who are refractory to ventricular tachycardias, especially with compromised left ventricular function. IV Procainamide is used for patients with hemodynamically stable ventricular tachycardia. It is one of the few drugs that acts on the accessory pathway in a patient with WPW. Now let's look at Quinidine. As I said, Quinidine is not commonly used for control of atrial fibrillation rate or conversion of atrial flutter. Quinidine is a class 1A antiarrhythmic which acts on the phase 0 of the action potential and also increases the refractory period, or it increases the QRS duration. It is primarily used, as I said, in patients with persistent ventricular tachycardia that is not responsive to conventional antiarrhythmic drugs used in patients with severe left ventricular dysfunction. The usual dose is 300 milligrams every 6 hours. We can give a loading dose of 600 to 1000 milligrams. Some of the side effects include decrease in blood pressure, nausea, or thrombocytopenia. The next drug in class 1A category is Procainamide, which decreases the speed of depolarization, which is phase 0, and prolongs repolarization, and that is phase 3. It is indicated in patients with atrial fibrillation, not very often, unless you are dealing with a patient with Wolff-Parkinson-White or WPW syndrome with atrial fibrillation and rapid ventricular response, where it blocks the accessory pathway. It is given as 50 milligrams IV and repeated every 5 minutes, up to 5 to 6 doses, and started with an infusion of 2 to 6 milligrams per minute. When Procainamide is given orally for control of ventricular arrhythmias, the usual dose is 500 milligrams every 6 hours to a maximum of 8 grams per day. Procainamide can cause myocardial depression, and one of the major side effects of Procainamide is lupus, and based on this you can guess it prolongs the QT interval. Diazoparamide is another class 1A antiarrhythmic drug similar to Quinidine and Procainamide, and the indications are mostly for ventricular arrhythmias It is given in a dose of 100 to 200 milligrams every 6 hours up to a maximum of 1200 milligrams per day. The dose has to be adjusted in patients with hepatic and renal failure. The side effects include urinary retention, lupus-like syndrome, and it also depresses the myocardium. It is contraindicated in second and third degree AV blocks. Lidocaine. Most of us are familiar with lidocaine. Lidocaine, in addition to acting on the phase 0 of the action potential or the sodium channel, it also shortens the refractory period. Unlike the class 1A drugs, it shortens the refractory period or the QT interval. Obviously, you have used lidocaine many times for treatment of ventricular arrhythmias, ventricular tachycardia, fibrillation. The initial dose is 1 to 1.25 milligram per kg IV over 3 to 5 minutes, which is repeated in a dose of 0.5 to 0.75 milligrams per kg IV. It is given as an intravenous infusion ranging from 1 to 4 milligram per minute. When we reach 3 to 4 milligrams per minute, we need to watch for central nervous systems, including numbness. The next drug in class 1B group is Miquelin, which again decreases the rate of depolarization and shortens the repolarization. It is used in patients with PVCs and ventricular arrhythmias. It is given orally in a dose of 200 milligrams every 8 hours up to a maximum of 1200 milligrams per day. Phenytoin is a class 1B drug which acts on the sodium channel and the potassium channel, that is phase 0 and phase 3 of the action potential. And since it shortens the repolarization phase, it shortens the QT interval. It is useful in patients with atrial and ventricular arrhythmias, especially resulting from digitalis toxicity. It may be useful in patients with prolonged QT interval because, as you can see here, it shortens the QT interval. Some of the side effects include nystagmus, ataxia, drowsiness, or coma. Now let's move on to class 1C drugs. Flecainide is a drug which acts on the sodium channel or phase 0. It has no effect on phase 2, 3, or 4. It is useful in patients with ventricular tachycardia, atrial flutter, and ventricular fibrillation. It is given in a dose of 50 to 150 milligrams twice daily, and it should be decreased by 50% if the GFR is less than 50 ml. Some of the side effects include dizziness, tremors, and worsening of heart failure. The next drug in class 1C group is propafenone, which decreases the speed of depolarization and shortens the repolarization, which is not shown in this particular diagram. It is useful in ventricular tachycardia, atrial fibrillation, and flutter. You have a loading dose of 600 milligrams followed by 150 to 300 milligrams every 8 hours up to a max of 1200 milligrams per day. The sustained release form can be given in a dose ranging from 225 to 425 milligrams 3 times a day or every 8 hours. The side effects include dizziness and worsening bronchospasm. It should be avoided in patients who are taking digoxin or warfarin. Now let's look at beta blockers. Class 2 antiarrhythmics include beta blockers which act on phase 4 or the resting membrane potential. There are mainly 3 drugs that we need to be concerned about: metoprolol, even nadolol, which can also be used. Then we have atenolol. Carvedilol is rarely used for control of arrhythmias. Then we have bisoprolol. Metoprolol is a very commonly used drug in patients with atrial fibrillation for control of rate. in a dose ranging from 12.5 to 100 milligrams twice daily. In addition to controlling the rate in patients with atrial fibrillation, it also helps to control the blood pressure and is also useful in patients with congestive heart failure. It is not suitable in patients with advanced chronic obstructive pulmonary disease, but however, chronic obstructive pulmonary disease is not a contraindication for use of beta blockers. Similarly, atenolol can be given in a dose ranging from 50 to 100 milligrams per day in either one or divided doses for control of atrial fibrillation, and beta blockers may be quite useful in patients with premature ventricular complexes. As I mentioned already, carvedilol is usually not used for control of arrhythmias. Bisoprolol is given in a dose of 1.25 to 10 milligrams daily, and some of the side effects include heart block, bradycardia, bronchospasm, hypotension, fatigue, and impotence. Beta blockers should be avoided in patients with second or higher degree AB block, and we should also be cautious about using beta blockers in combination with calcium channel blockers, where both agents can depress left ventricular function. Now let's look at drugs in class 3 group. The class 3 antiarrhythmics work on phase 3 of the action potential, which is the repolarization phase, which is brought about by potassium channel. So basically, the class 3 antiarrhythmics block the potassium channel and prolong the refractory period, prolong the repolarization phase. So the drugs in this category include Sotalol, which blocks the potassium channel and prolongs the action potential. Sotalol is useful in patients with PVCs and ventricular tachycardia or supraventricular tachycardia. It's most commonly given in patients with PVCs or short runs of ventricular tachycardia. It is given in a dose ranging from 40 to 160 milligrams twice daily. Sotalol can make the heart failure worse. It can also cause bradycardia and bronchospasm, and occasionally it can cause torsade. It is contraindicated in patients with chronic kidney disease. The next drug in class 3 group is Beaufort Allied, which again blocks the sodium channel and prolongs the phase 3 of the action potential. It's indicated just like Sotalol in patients with PVCs, ventricular tachycardia, more often, and it can also be used in patients with atrial fibrillation. The dose ranges from 125 to 500 micrograms twice daily. The side effects include dizziness, diarrhea, and possible torsade. Now we move on to class 4 antiarrhythmics. The drugs in this category belong to the calcium channel blocker group. The most commonly used drugs are verapamil and cardizem, and this works on phase 2, which is basically the calcium channel, and as its name indicates, it blocks the calcium channel. This is the calcium channel blocker, and they have a predominant effect on the sinus node and the AV nodes. Hence, they are quite useful in controlling rates in patients with atrial fibrillation, and also it helps in ventricular tachycardia. Verapamil can be given in a dose ranging from 40 to 80 milligrams every 8 hours, or we can use long-acting verapamil in patients who can tolerate. Verapamil causes weakness and fatigue. Verapamil is particularly useful in patients with atrial fibrillation who have rapid ventricular response and also have significant obstructive airway disease, which prevents us from using beta blockers. And in these patients, verapamil may be quite useful in controlling the ventricular rate in the presence of atrial fibrillation. However, since verapamil and diltiazem both depress left ventricular function, they should be avoided in patients if they have a left ventricular ejection fraction of less than 40% or second degree or higher AV block. We should not use this in combination with other beta blocking agents. Diltiazem works similar to verapamil, and the beauty of diltiazem is it can be given intravenously in an emergency situation when we face patients with atrial fibrillation with rapid ventricular response. It can be given as a 15 milligram. It can be given as a 15 milligram bolus over 1 to 2 minutes, and we can repeat that in 30 minutes, and this can be followed with an infusion of 0.005 milligrams per kg per minute to maintain the ventricular rate in patients with atrial fibrillation. It causes weakness and fatigue. It can also be useful in managing blood pressure, but it should not be used in patients with left ventricular ejection fraction of less than 40%. So, verapamil is very useful in patients with chronic atrial fibrillation with rapid ventricular response. Diltiazem is very useful in patients with acute atrial fibrillation with rapid ventricular response. However, diltiazem is not the best choice in controlling ventricular rate in patients with chronic atrial fibrillation. I would rather choose beta blockers or choose other antiarrhythmics which does not depress the left ventricular function. There are a couple of other classes of antiarrhythmics that we routinely use, which do not belong to the four classes of antiarrhythmics. Amiodarone and dronedarone belong to one class where these drugs act on multiple phases of the action potential. In fact, the amiodarone and dronedarone work on the sodium channel, that is phase 0. They also work on the calcium channel, which is phase 2, and they also work on the potassium channel, which is phase 3 of the action potential. Amiodarone is useful in patients with chronic atrial fibrillation and also in patients with ventricular tachycardia and fibrillation. It is one of the most commonly used drugs in patients with ventricular arrhythmias, especially those who have significantly depressed left ventricular function. Whereas dronedarone is mainly used in patients with paroxysmal atrial fibrillation to prevent the recurrence of atrial fibrillation. The dose of amiodarone is 200 to 400 milligrams given twice daily up to a maximum of 1.2 to 1.8 grams per day. Amiodarone can also be given in an acute situation as an intravenous drip ranging from 0.5 to 4 milligrams per minute. Dronedarone is given twice daily, and its predominant use is in patients with paroxysmal atrial fibrillation to prevent the recurrence of atrial fibrillation. The well-known side effects of amiodarone and dronedarone include pulmonary fibrosis and bradycardia. They are contraindicated in patients with WPW. One more drug that we very commonly use, which does not belong to the classic four classes of antiarrhythmics, and this is the adenosine receptor blocker, which is used predominantly for control of supraventricular tachycardia, atrial flutter, or fibrillation. Adenosine is given as an initial dose of 6 milligrams bolus. That can be followed by 12 milligrams of bolus on 2 occasions, and if we are injecting this drug through a central line, the dosage should be reduced by at least 50% or so. It is not uncommon to see a patient in the emergency room whom you give adenosine and all of a sudden you see a full screen of straight line. Don't be scared, because that is secondary to blockade in the sinus node, and eventually the sinus node will pick up and the sinus rhythm will resume. Other side effects include flushing, dyspnea, and chest pain. This is contraindicated in patients with a WPW because by blocking the normal pathways, the acceleration through the accessory pathway may get worse. Digoxin. Digoxin is been around for almost 100 years or so. Digoxin is very useful in patients with atrial fibrillation for control of rate in an acute situation and also on an outpatient basis. Digoxin works by increasing the vagal tone in addition to improving left ventricular contractility, and it increases the AV block. Digoxin is useful in controlling ventricular rate in patients with atrial fibrillation or flutter, and of course it is also useful in patients with acute heart failure where it improves the symptoms of heart failure. The digoxin dose has to be adjusted based on the serum creatinine, GFR, body mass index, and age. If we are using digoxin in an ICU setup for control of ventricular response in a patient with atrial fibrillation, they can be just given 0.25 milligrams digoxin IV and washed. After several hours, the dose can be repeated. We do not need the loading dose as we used to use it in patients with heart failure. If the first dose is not able to reduce the ventricular response, a second dose can be given in 6 hours and followed by close observation. The maintenance dose of digoxin is 0.125 to 0.25 milligrams per day or 3 days in a week in patients with renal failure or those who are on dialysis. In patients with atrial fibrillation, rate control should be less than 1 nanograms per ml. When the digoxin level goes above 2 nanograms per ml, we may see symptoms of digitalis toxicity such as ventricular ectopic beats. So, ladies and gentlemen, this is a brief overview of antiarrhythmic drugs based on their effects on the various phases of the action potential. Thank you so much for watching, and please do subscribe to our YouTube channel. In the next presentation, we are going to focus on management of a patient in an acute situation with atrial fibrillation and rapid ventricular response. Thank you again for your attention.